Hey everyone, my name's Tiffany Moore, and I'm so excited to share with you quantitative designs and levels of evidence. So I've kind of broken this lecture up into just like three videos that you can watch, and hopefully it won't be too overwhelming, and hopefully you'll learn something. So we're going to talk about quantitative methods, and you may appreciate this little cartoon here. So kind of the difference between quantitative and qualitative methods would be, hey, so only 1 in 30 take the free ice cream. Oh, that's very interesting. Whereas qualitative would ask, how do you feel when you saw the free ice cream? Excited, a little scared. Oh, why was that? So qualitative looks at words, and quantitative, we look at numbers. So you can see a couple examples of graphs or charts. These are usually what you'll see associated with quantitative research. When we're looking at evidence and we're looking at designs and study designs and research, we a lot of times will categorize them into different levels of evidence. So the top of the pyramid is your best research, where you can really be, pretty confident that that there's a lot of research to support a change in practice, let's say. Uh, Today, we're going to be talking about levels 1, 2, 3, and 4. When you think about levels of evidence, you can also think of it like levels of chocolate. Now, I don't know about you guys, but I immediately fell in love with Nestle's Quick. Also, Hershey's chocolate syrup that you just add into your milk and stir it in and drink it up. That is just delicious. When I was younger, when I tried a Godiva chocolate, I don't think I really liked it. In fact, I know I didn't like it. If you've ever tried different types of chocolates, sometimes the more expensive chocolates are more pure and richer, and they sometimes don't taste as good. Don't tell them that. You have to kind of acquire a taste to the chocolate. And so that's kind of how levels of evidence are. There's not as many Godiva chocolates as there are Nestle's Quick or Hershey's chocolate syrup. There's not as many systematic reviews and level one evidence, but that is the best evidence. And supposedly, Godiva truffles are the best chocolate. So we'll start with level one evidence. This is your meta-analysis or comprehensive systematic review. This is the highest level of evidence. And this is usually what we try and base our evidence-based practice on. So if you're wondering what protocol is better to do this intervention, to start an IV or to draw blood from somebody, what's the best method to use? Well, you're going to look in the evidence and you're going to see what research has been done. Well, this is the top of the research. And usually what happens is with this level one, it's multiple research studies that combine and you analyze them all together to really say, okay, yes, all of these research studies agree that this is the way that you're going to draw blood. This is the best way to draw blood. So I say the word systematic review, and you may think that I mean a literature review. So they are very different. So a traditional literature review just chooses a few articles. So like something you would read in a magazine. Well, they may, reference somebody, but it's just 1 or 2 articles. So there's really not a lot of rigor. There's not a lot of meat to that review. And it can be heavily biased. If you have all this literature in front of you and you choose the 2 articles that are your favorite, well, you're going to kind of be biased about what you choose to support what you think. So which is better, the systematic review or the literature review? Well, it just depends on what you're using it for. In reality, if we're talking about research, a systematic review is better than a literature review because it's systematic. It means you looked at every article in the literature. You looked at every source and included that in. So it's like an exhaustive search. And you can really trust a systematic review as a source of evidence. Even though you didn't really like collect data from people, you collected data from a bunch of articles. However, it's very hard to read and to understand sometimes because, again, it's so comprehensive, it can be a bit overwhelming. So we're used to reading um, literature reviews, just summaries of a few things in the literature. More about a systematic review. It's like a high-level overview of a bunch of research studies, okay? And so you ask a research question, and then you try and find all the articles that support that research question. And it's very systematic in how you do it. You keep a list of what you do. You have somebody that also looks at the articles and makes sure that you're not being biased. So you choose, yes, this article fits my criteria. No, this article does not. And if the two people don't agree, then they have to come to an agreement or bring a third person in to make that determination. So it's very rigorous. It's very like I said, systematic. I mean, think of like military, just very uh, cross all your T's, dot all your I's. It's very this, then this, then this, then this, then this. Here's an example of what a systematic review would look like. So when you look at this data sources and searches, so you look at the methods. The methods usually tell you about the sample, about the people and where they're from. And, we recruited 20 pregnant women from a Midwest university. Well, here they're going to talk about what databases they used. And then they're going to talk about the search terms and their search strategies. And then they're also going to talk about the reviewers and to make sure there's no bias. So see how this disagreements between the two reviewers were resolved by discussion and consultation with a senior advisor. So you can see that these are the criteria they used. They used variables. So again, it's very similar to research, but you're researching articles instead. So a meta-analysis is a type of systematic review. So I've just been talking about a systematic review, just kind of an umbrella, and just saying, okay, we look at what do all of these articles say. Now, what's really cool and very intimidating is you can do a statistical analysis on the results. So it's basically a research study of many research studies. So you do statistics on the statistics that they did in the statistical section of the papers. How's that? So if you want to see how effective this procedure is, we'll go with the drawing blood, and you want to see the effect the intervention has versus this procedure, you're going to do a statistical test on the results of all of the procedures in this group and in this group. So basically, it's just a really big statistical analysis. And I have to tell you that those who are experts in statistical analyses, very few of them will tackle a meta-analysis because it's very confusing. It goes way over my head. But I understand and appreciate that that a meta-analysis is really provides strong, strong data. So here's an example of data and synthesis analysis of a meta-analysis. So you can see that this all uses words that you've probably never heard before. And but basically what they talk about is the statistics that they did on the statistics. How many times have I said that now? Clinical practice guidelines. Um, these are systematically developed statements. So pretty much they're statements that are created by a group of experts who read and critique and prioritize the evidence. So usually it's based off of level 1 systematic reviews, meta-analyses that we just talked about. And these are the guidelines that people use for evidence-based practice. So instead of just one article, you can think of this as a group of experts getting in a big room together and looking at multiple systematic reviews and saying, okay, this is how we suggest that you draw blood. This is how we suggest you take temperatures. This is how we suggest you treat temperatures. This shows the best evidence. So clinical practice guidelines are a type of level one evidence because they have brought all the evidence together and said, okay, this is how you should do XYZ procedure. And really to keep practice, to keep from there being variations in practice so that every patient gets treated with consistently high quality care. These are just some of the libraries or resources for accessible clinical practice guidelines. Really, if you differentiate systematic reviews and clinical practice guidelines, they both have the word systematic in it because it's very, again, formal and rigid in how they go about producing the results. But one answers a research question and one guides practice. So the clinical practice guidelines guide practice, and your systematic review answers a research question. Another difference is the authors. For clinical practice guidelines, you really want those authors to be expert clinicians, expert scientists in that area. And in a systematic review, as long as you know how to do a systematic review, you don't have to be an expert in that specific area because you are an expert in the methods of analyzing literature. Let's talk about level 2 evidence. So we went from level 1 evidence with looking at a bunch of research studies. Now we're going to look at individual research studies. So level 2 evidence are going to be your experimental, also known as intervention studies, that are randomized. So they're a randomized controlled clinical trial. So maybe you've heard of those before. You'll hear double-blinded, single-blinded, randomized controlled trial, randomized controlled study, those kind of words. So what the randomization does is it removes bias. So essentially, usually the most common way to randomize is to, when you recruit someone, they either go in intervention A or intervention B. And a lot of times intervention A is the actual intervention and B is a placebo. So think of it like with medications. You can be given a certain medication and a placebo medication. If you're doing like a behavioral exercise intervention, you would give them the exercise intervention, and then the control group or the placebo group would just get maybe education, but they wouldn't get the actual intervention. But then where randomization comes in is you recruit them to the study, and based on a sequence of numbers that a computer can generate, maybe 1, 2, and 3 go into A, 4 goes into B, 5 goes into A, 6, 7 go into group B. So they just randomly put them into an intervention or the control group. And again, it's done by a computer process. So the human does not decide, oh, I'm just going to randomly put them in. No, it's like really random. It's a computer generated process. So you can have single. So single blinded means that uh, the participant doesn't know which one they're in, and a double-blinded means not even the scientist or the primary investigator knows which group they're in. And that's easiest to do when it's a drug because you can make them look the same. In clinical research, the kind of research that I do, that would be very difficult uh, to not know which intervention group. So, for example, the exercise intervention group, you're going to know if they got the exercise intervention. They're going to know if they got the exercise intervention, and they're going to know if they just got the education. So rarely do you have a double-blinded designed, but that is the ideal, is so that there's absolutely no bias. So some fancy words: independent variable is the intervention. So they both have the letter I at the beginning. So for future reference, when you're learning about independent variables, that's the intervention. And then the dependent variable, that's really your outcome. So what you're looking at. So we're looking at the intervention would be exercise, and the outcome would be weight loss. This is an example of what you would see in the literature when describing kind of the systematic way that the clinical trial went. So you can see they started with this many eligible patients and they excluded this many because X, Y, and Z. So they had 27 that they randomized into the two groups, okay? And then you talk about whether or not people stayed in the group and how many completed the trial. So this really just shows that really decreases the bias or any questions that anyone outside the study would have about really the legitimacy of the study. So when you talk about a level 3, this is also an experimental design, okay? But we call it a quasi-experimental because it's not quite a level 2, but it's still an intervention. And the biggest thing that's missing in a level 3 quasi-experimental is the randomization. So really, that means you are looking at maybe a pre-post test on the same students. So everybody got the same intervention. Well, they weren't randomized and you didn't have a control group. So that's quasi-experimental, right? That's still experimental, but it's not quite level 2. But let's say you have a group and you just out of convenience, you're going to be in the intervention group and you're going to be in the control group. Again, there's no randomization that really increases bias. So that would be a quasi-experimental level 3. Okay, here we go. Let's ask a question. What is the difference between level 2 and level 3? What is that big fancy word that I use a lot? Should I play Jeopardy? No. Randomization. If you said that, yay, you get kudos. So now we're going to talk about non-experimental designs. Okay, so level 1 was its own thing, right? It's a bunch of studies all together that you're looking at. Level 2 is a single experiment, so you have an intervention. Level 3 is a single experiment, you have an intervention, but there's no randomization. Level 4 is a non-experimental. It's still quantitative. You're still measuring and using numbers, but you're not doing an intervention. You're not doing any sort of experiment. Instead, you're looking at the data. You're describing, you're explaining, you're predicting. So if you heard my talk before about my own research, all of my research thus far has been level 4, because without describing phenomenon, you can't try and intervene. And so again, experimental, non-experimental, level 4 evidence is still really important evidence. We just don't know enough to be able to do an intervention. So again, this describes, it explains relationships, you can predict relationships. Types of designs are descriptive, so just think of they're describing. Correlation, all right, so they're looking to see if they have relationships. If this is high, is this high or is this low? So if someone drinks a lot of Pepsi throughout the day, do they have better sleep or worse sleep? So that's kind of a correlational. You're not doing an intervention, you're just looking at the data. A case study is a type of level 4 non-experimental. So case studies where you look at usually 1 or 2 patients and you just kind of observe. And then another type of non-experimental is qualitative, but I believe somebody else is talking about qualitative, so I won't touch on those today. A descriptive design. So again, it's a type of non-experimental design, but it's still quantitative. So a lot of times you'll hear the words explore or you'll hear the words compare. We're going to compare this group and that group on age or on ice cream flavor or whatever you want to compare. A lot of times it involves a survey. If you remember with my research, I look at biomarkers. So I look at outcomes and biomarkers, and I try to find relationships. So these descriptive designs, really just kind of describe what did my patients look like. Correlation design then takes it just a step further from a descriptive design, and it says, so how is this related to this? So if they like chocolate ice cream, do they like ice cream cones? I don't know, that's a really bad example, but kind of looking at relationships. No experiment, but we're just kind of, we've described, okay, so 5 men and 4 women like chocolate ice cream compared to 10 men and 20 women who like strawberry ice cream. And then we also looked at whether they used a cone or a dish. So do the men who like chocolate ice cream use a cone or a dish? So you get the point. We're looking at relationships. So not causality, okay? So we're not saying, all right, because they like chocolate, they're gonna like a cone. That's not what we're looking at. We're just looking at relationships. First you look at the data, describe it, and then you kind of compare things. And then maybe you can kind of predict, if you get enough data, you might be able to predict, all right, that guy's choosing chocolate ice cream. I predict he's going to use a cone. And then you can do model testing and correlational design. Sounds fancy, but basically it's just proposing a theory, a model, a theoretical model, and testing those relationships and saying, hey, I think that stress biomarkers correlate with feeding intolerance. And so, and you can see that in my model here, if you remember my research talk. So let's talk about a questionnaire was used to identify anxiety levels in nursing students before an exam. And I underlined a key word there, a questionnaire. What level of evidence is this study? If you guessed 4, boom, you're correct. So this is just a descriptive study. We're just looking at anxiety levels in all nursing students or in this particular class before an exam. We didn't do an intervention, but we still looked at anxiety levels, which would be a number, right? Because we can measure anxiety. Now, what if a questionnaire was used to identify anxiety levels before and after nursing students were randomized to participate in a breathing intervention? All right, so there's some keywords. Yes, we're still using a questionnaire, but these are bigger keywords. Before and after randomized intervention, level of evidence is, boom, a 2. Congratulations if you got that. It's okay if you didn't, because I'm throwing a lot of new terms at you and it can be a bit overwhelming. And yeah. So selecting the best quantitative design. If experimental studies, you're looking at causality. So you're going to have an intervention. And you remember we talked about the independent variable is the intervention and the dependent variable is the outcome. Or you can look at a non-experimental study where you're looking at probability and relationships and just kind of, you're just kind of looking right now. You're not trying to fix anything. You're just kind of looking at the problem and seeing ways that might work to fix it. Now, something that you should always, always do is question study results. Always. These two fancy words, internal validity and external validity. Basically, you want to know, is there something about the participants in the study that's why they responded to the intervention? Or external validity would say, now, okay, it worked in this high school group, but would it work in this high school group across the country that live on the other side of the country, or live on a coast? Or this worked in this rural town, will it work in the city? So that's kind of external validity. So breaking it down more, the threats to internal validity are selection bias. So if I, as the researcher, as the investigator, choose who I want to be in my research, that is bias, which is why we randomize to remove bias. So an example might be, okay, I want to see if my breathing exercise works to reduce anxiety. So I'm going to pick my best students to have the breathing exercise and see if their scores, if they have high scores. Well, my best students are probably going to have high scores anyway. So that's kind of some selection bias. History. So a lot of times research studies are conducted over a period of time. So you don't just have one day where you recruit all your people and get all your information. Usually you recruit over several months. So you're asking the same questions, but maybe you recruited someone in September and then in December. And so you have to know what's going on in the history. My best example for this is if you were to study patriotism um, in New York City, and you started the study in July of 2001, and you collected data and continued to recruit patients through December 2001. Now, knowing our history, something really important happened on September 11th, 2001. Now, that would probably affect patriotism and levels of, how many people displayed the American flag, or whatever you want to give the example of. But that would definitely affect your levels before and after September 11th. So that's an example of history. Maturation, if you're studying someone's anxiety levels, for example, at the first day of nursing school to the last day of nursing school, well, they've probably matured. They're a couple years older. They're in the groove now. They understand how these tests go. So just the maturation alone would improve scores. Testing, you need to make sure that they don't remember the questions on the first pre-test, let's say, and that they just repeated the answers, and so that's why they did well, or they remembered their answers, or however. Instrumentation, make sure all the instruments are working. If you're using a scale that is 5 pounds off, either way, that's going to affect your data from this person to this person to this person. And then mortality or attrition. We more look at attrition. So remember how we looked at if there were participants that stayed in the study and how many dropped out of the study? That's attrition. So if you can keep as many patients as you can in the study, that's really important. But let's say, for example, that your intervention group had half of the people drop out of the study. Well, that is really telling. You may have a good result, but half the people didn't want to finish the study. So you would, really have a threat to internal validity and say, there's something with this study that half the people didn't want to do it. So there's something wrong with this study. Now, when we talk about external validity, some big words on this slide, but basically you want to make sure that there isn't anything that had to do, it's just because this group of this sample here, you know, because they were located at the right place at the right time that it worked for them. You want to make sure that that the study will work in multiple populations. So one thing to think about when we're looking at quantitative designs is a lot of times you categorize them by time. So retrospective means the data has already been collected, and then you ask your research question, and then you look in the data to answer that research question. Cross-sectional is just one moment in time that you look at, okay? Longitudinal is when you look at multiple time points. So that study that I did with pregnant women where I collected blood throughout pregnancy and in the cord blood and in the baby, that's a longitudinal study because I wanted to see levels over time. A prospective study can be cross-sectional or longitudinal. So kind of retrospective. So retrospective and prospective are kind of opposites. So if it's retrospective, that means you had your research question and the data has already been collected. So a lot of times if you're looking at electronic health records, you can ask a question and then look in the data. A prospective, you haven't collected the data yet, so there's no bias, and you prospectively ask your question and then you collect your data. So it's just kind of some differences, some fancy words that just kind of, again, will affect your validity, that internal and external validity. I did want to mention, we've talked about populations and samples. I did want to mention that your sample is actually the people that you recruit. So the moms that I recruited in my research study, that was my sample. This accessible population would be then all of those women that were at Nebraska Medicine that I approached that were eligible. They're the ones I had access to. Target population then would be pregnant women. And then general population would just be women. So you can kind of see it just gets narrower and narrower. But the thing that's important is that the sample is the group that you actually had in your study. And usually it's important to know who your target population is and where your accessible population is. Okay, so let's talk a little bit about statistics. I'll try to make this as painless as possible. I like to start out with this cartoon because here is a chart that shows what you might see if you looked at a mountain range through a tennis racket. Because sometimes when you're looking at data, you don't know what you're looking at. So why wouldn't it be a mountain range through when you're looking through a tennis racket? So they're descriptive statistics and inferential statistics. So the descriptive statistics describes, summarizes, synthesizes the data. So which level of evidence are we only going to use descriptive statistics? Level 4 evidence, where we're just describing, right? We're just describing the population. Now, inferential statistics we're going to use for our experimental studies. So we'll also describe, the sample when we are doing an intervention study, but then we'll take it a step further and we'll do inferential statistics, which is really drawing conclusions. You are looking at relationships again. So you can use some inferential statistics for those studies when you're comparing this and that. But you'll definitely use your inferential statistics when you're looking at comparing the outcomes after an intervention. So we think about descriptive statistics. It describes the results. So in this study, there were 7 first graders and 10 second graders. And that N symbolizes sample. So an N of 7 means a sample of 7. And let's just say another descriptive statistic would be 50% answered yes. Or you can say the number, which is 45 of the participants answered no. So again, it's just really black and white. You're just describing the literature. Inferential statistics then, after you've described the sample and used your descriptive statistics, then you test your hypotheses or test your relationships that you were wondering about. And again, this is used in experimental and quasi-experimental studies. Now, you also use them in some of the level 4 because, like, for example, I wanted to see how the stress biomarkers compared with feeding intolerance in preterm infants. So I did use some inferential statistics there. But you definitely use inferential statistics to test an experiment. Now, don't be overwhelmed with this slide. Basically, I want to just show you that right here is your hypothesis. So people who eat chocolate ice cream prefer a cone over a cup. And your null hypothesis says there's no difference in whether they like chocolate ice cream and whether they want a cone or a cup. And so what you're trying to determine is if your statistic your inferential statistic that you compared ends up in this area right here. And we can control for errors. So to really, decrease chance. So you can be sure, like 0.001% sure that this did not happen by chance. By changing different types of errors in your statistics. Don't need to know all the details in that, but there are ways to adjust p-values and power and fancy words to make sure that that arrow, that margin that you're trying to find, that your relationship isn't there because of chance. Okay, so this is just kind of showing how your null hypothesis and your alternative hypothesis, your actual hypothesis, how they coincide, and how this little piece here is what says, yes, there is a significant difference between this and that. So when you're reading statistical tables, you'll start to get used to the symbols used, like that N. N is sample. But read the title first. Pay attention to the access, to the different footnotes that they use. A lot of times they tell us a table and a figure should be able to stand by themselves. And so if you kind of look at it more, I mean, you can see what's higher and what's lower, right? They don't need to make it super fancy. You can see that this group was higher and this group was lower. A lot of times, if it's a significant difference, it will have an asterisk level. But again, look in your footnotes and see what the asterisk means. Let's see, and understand that there may be typos or math errors. And yeah, so just sometimes I feel like looking at tables and figures are easier and make more sense to me than just reading a bunch of numbers in the main literature and the writing. So, if you're reading something and you're like, I don't understand this, try looking at a table or a figure, and that might just really kind of get to the point for you. I want to briefly touch on a power analysis. And basically, this is just a statistical method, okay, so a computer does it, that helps you to determine your sample size. Have you ever wondered why some studies have 20 and some studies have 200 or 2,000? Well, a power analysis is something that you usually do before, so a priori, before a study to say, okay, if I want this much difference between cones and cups, so there's a 30% difference, how many how many subjects, participants do I need to show this difference? And a mathematical equation will say you need 30 participants in each group, or you need 300 participants in each group. And again, that's kind of higher level, but it's something to just understand and that you should look for to help determine why did they choose that sample size? And is that sample size big enough to really tell if there is a difference between A and B? So a lot of times that's why they call them pilot studies, is because they aren't big enough to really determine if there's a significant difference. But it's just a pilot study to just kind of see if there's a little bit of difference, to see if it's feasible to do this study or not. And I want to end by talking about ethics. It's important to make sure that you safeguard the rights of the subjects when you're talking about any type of research. You should always assess the associated benefits and risks of any intervention or test. So there are many institutional boards that oversee anything that I do as a researcher. I have to get approved to, especially if I'm going to do anything with students, any intervention, they really look at the risks and benefits, and it has to benefit. Um, it may not benefit that patient right then, but it needs to benefit in the future or something, and it really needs to be minimal risk. It really is an obligation of the researcher to minimize subject burden. So if I'm going to give somebody a questionnaire, I don't want that questionnaire, I don't want to give them 100 questionnaires that's going to take them 2 hours. That's a lot of burden on the subject. So you try to minimize the burden, and you ensure that the strategies used are sensitive to the rights of the subjects. So for example, you know, if when a physician is part of a research study, they should not recruit their own patients, because the patient may feel obligated because, well, if I don't participate in the research, are they still going to take good care of me? So that's why an independent researcher needs to come and recruit that patient. And that's just one example of being sensitive to the rights of subjects. Other things are to think about vulnerable populations. Now, I work with preterm infants, so I need parental consent, because that baby can't make a decision if they want to be in the research study. You need to think about vulnerable populations such as pregnant women. If there's an intervention, will it at all put the fetus at risk? If it does put the fetus at risk, it needs to have mom and dad approval. Other vulnerable populations would be prisoners, um, uh, really just in any type of vulnerable population. If you are a homeless population, they're going to be very vulnerable, because if you give any sort of incentive, um, you know, they're going to do whatever just to get that incentive. And so you need to make sure that you really consider these vulnerable populations. Confidentiality, if it can be anonymous, if you don't need to know their birth date, if you don't need to know their address, you don't collect it. We try to keep information as confidential as possible. For example, since I do collect protected health information, so like age and email address and medical record number, I give all my patients a subject ID number. Now it's like 361. Only I know who 361 really is. And I keep that document that says 361 is Tim Jones. I keep that in a separate file labeled something completely different, so that no one can ever get access to who 361 is. Informed consent is essential. People have to know what they're agreeing to. And so usually it's starting to be standard of practice to kind of use the teach back method. So I ask my patients, now that I told you all of this, kind of like with you guys, you tell me what you are agreeing to do. And if they get the gist of it, you're going to draw my blood and blood from my baby at different times throughout the pregnancy. They don't need to know at 12 weeks, at 24 weeks. They need to get the gist of what they have to do. So then that's informed consent. Assent means that if it's a pediatric patient, so like a child over the age of 7. So let's say I have a 15-year-old. Well, I still need parental consent because the patient is a minor, but that child is old enough to make a decision. So I need to make sure that I get their permission as well. So the patient has to agree and the parent has to agree. Otherwise, not happening. And then coercion, again, that's kind of incentives or I always tell my patients, whether or not you are in this research study will not affect your care by your doctors. These doctors and nurses are still going to take very good care of you. And then the incentive is usually it needs to be something reasonable. So usually like $20 an hour. So if if I have surveys that they need to fill out and it's going to be about 45 minutes, then they usually get like a $20 gift card. So those are some things that you need to really keep in mind and really keep it ethical. And the good news though is that there are lots of people out there looking to make sure that the participant is safe and has their rights and know their rights and are safe. Yeah. So that's the end of my talk. I hope you enjoyed that. I hope you learned something and it wasn't too overwhelming. If you have any questions, please feel free to contact me. I would love that. So have a great day and thanks for paying attention.